Yeah, I think we can start.
Um, Good evening, everyone. Welcome to today's CME. We are happy to invite you to this series, and today we are going to have a very interesting talk from Mr. Newton Siele. My name is Dr. Eunice Ngatia. I want to invite you. Microphone so that you may not cause any distraction during the CME. So I think we have achieved adequate quorum. So I will introduce the speaker for today. The speaker for today is Mr. Newton Siele. He is the CEO of Phillips Therapeutics. He is not just a successful CEO, but also a renowned leadership coach. He has been through Phillips Top 100 program and has coached many young leaders into successful managers. So he will be taking us through the topic of leading change in any organization. I think at this particular point, this is a very important thing for all of us in our profession to have leadership skills. So we are going to invite Mr. Newton. Welcome to the floor. And if you have any questions, kindly do not hesitate to comment on the chat box. Welcome, Mr. Newton.
Dr. Katia, and it's indeed an honor to be I do hope that the topic will resonate. It was a topic, of course, that was chosen by the leadership. Let me share my screen. So I'll try and endeavor just to sort of to package it and hopefully the topic is going to resonate and also be relevant in terms of its application. From where I sit at my position, I think one of the biggest challenges we usually see with young leaders is just the perspective of fast initiating change, and as we've seen, usually trying to push through that change. Often we change because it's something that needs to give way. And the biggest challenge I think most people tend to have is just successfully navigating change. And that's what we'll talk about. In terms of change, people change what they do less because they're given analysis that shift their thinking than because they're shown a truth that influences their feelings. As I said, usually we tend to have this assumption that when you want to drive change in people, just give them the analysis of why they should change. This has also shifted because initially a lot of the work that had been done on change, that's not necessarily people to see actually what that change is about, and we'll see, and more likely to want to change. And that if you then successful organization or a team or a department, because some of the changes, you also, of course, as a leader or a person that is championing the change, you should be able to know how to overcome those antibodies that reject the change. The truth is actually, and I'd like to crystallize this at the beginning of my presentation, The heart of change is emotions. And it's surprising that they are less likely to change. So in terms of change, typical stages of change, when we initially change, there was, of course, I would say, great deal of work that had been done by a lot of previous research, and it had really been crystallized into most common stages that we talk about to a sense of urgency. Whatever it is you want to drive a change, the first step is making sure that everybody understands there's a sense of urgency. And that the second step is making sure that you have the right team that's going to be able to help you to drive that change within the team, the department, or the organization. And that our assumption also is that you have clarity about the vision for the change. And once you have the clarity about the vision, you then communicate that change to the people, to the institution, and of course also communicate the strategies that they need to be able to adopt so that they can successfully drive the change. As you begin to do that, we see that there's usually a need to remove barriers to action, because remember, again, unless there's action, you will not really be able to have any change. And when you begin having small wins, you use those small wins to create, of course, a snowball effect. And that wave after wave is what eventually leads to a successful change. And so we'll sort of dive in, as I said, but do bear with me because I want to contrast what I say is a traditional change approach with what I say is we are seeing a lot more as a reality where people really want to just feel, they want to see, and then they can be able to change. And I know for most of us here, whether you're leading a department, whether you've just been appointed, whether you are working within the hospital management, sometimes, in fact, change could be in your own business, it could be in your own clinic, it could be in your own institution, for those, for example, that are teaching. How do you navigate and successfully introduce change? But before I do that, I want to highlight again something that is very important. Changes can either be small or they can be big. And of course, whether the changes are small or they are big, what we have often known is that it requires a shift in priorities and strategies. And that in itself also means that you will most likely go through the usual steps that we have seen. So whether you are a leader, whether you're a departmental head, whether you're uh, the the head of the team, the head of the, as I said again, department or clinic, whatever organization that you're working with, your biggest task when it comes to change is to plan. And I really want to sort of echo here that you cannot go in without having a proper methodology of how you want to drive that change. Number two, you also have to be very familiar with the behaviors and the methods and the techniques that you're going to introduce that change. I say this because having worked with a number of organizations, a number of hospitals, a number of clinics, a number of different leaderships, both even in academic institutions, usually the one mistake sometimes we make is forgetting that we are also dealing with people. And therefore, if you're dealing with people, to successfully drive the change, you must create the right conditions. And I'm really honored to be speaking, of course, to experts who are in critical care. You know that for the patient to be put in preparation for surgery, the conditions have to be almost in sync so that the patient's life is sustained and the surgery is able to be successfully done. So if you think about it, driving change also means that we need to have the right conditions. And of course, ultimately, as we would see, nobody likes change. And so we usually say that leading change is not for the faint-hearted. I'm not political, but I want to be cognizant, for example, of certain institutions that have really been successful in shifting either their approach. And one of the reasons why they've done that is that they've really taken time to be able to prepare, to be able to execute, and probably some of the steps that we will be talking about. So I'm sure you'd ask me, Newton, are you saying that people today don't like change? It's not just today. What we know actually is that it's almost inherently very close to saying that it's genetic. Human beings don't like change. And especially when people perceive that a change is going to be bad, they push back. they push back. If, for example, an institution or a hospital decided they want to go paperless, or they want to adopt more AI, or they whatever it is that you think about it, there's so many changes that tend to happen anyway, even in terms of practice. More often than not, the first reaction that people will do is to put, and what it can be passive resistance, it can be active resistance, where people, will they'll tell you on your, no, we don't agree with the change that you're proposing. It can also be sabotage, meaning that you have a meeting, you propose, or maybe you take people through the change that needs to happen, and people don't say anything. But the moment they leave the meeting, they very quickly default back to what they know. So they, in essence, sabotage that change. That's what we call resistance to change. And I want to not to sound like a prophet of going to be in leadership. Anybody who is going to be driving, regardless of what change you're going to have, you will always never miss to have resistance happening in one way or another. And so, how do people react to change? Most common one is denial, and people continue to work as if nothing has changed. Sometimes they can be passive aggressive. Sometimes people can come to grips with the change. By the way, I mean, people have really studied, for example, the effect of COVID-19, and really how that sort of drove people. Initially, of course, people were in denial, but as you begin to see, people tend to move sometimes. And in fact, we've seen that the graph of resistance tend to go up slightly. And as I said earlier, you can have active, you can have passive resistance, you can even have sabotage, right? That happens as part of a change reaction. And often it's also tests the leader or the change champion that is trying to initiate within the organization. And that really happens. But what we see is that slowly people then begin to thaw slightly, and then they begin to be a bit cautious. Some will begin to appreciate that it looks like this change is going to benefit the institution. So we are shifting, for example, maybe from using ETO and sterilization. Now we want to go to plasma sterilization. So there's a lot of change that needs to happen, or the way we are going to be sterilizing our scopes, wherever it is that you're looking at. More often than not, people begin to say, okay, there could be certain benefits that we will have. So if we become paperless, and now we can also have access to very advanced intelligence that can also help us in terms of analyzing our differential diagnosis, whatever it is, people begin to be open to the idea of change. And usually, if you're successful, then they begin to engage, or they begin to embrace it. That's, I would say, is the ideal pathway that change tends to take. But one thing that has never really changed from history is that human beings resist being changed. And usually, in fact, that even becomes much more difficult and more painful to the people that are leading the change when they don't take time to involve, to listen, and to empower the people in the process. So we've always seen that sometimes the outcomes always are different from when the initiators impose the change. And I know that, as again, for most of you, we are within the ministry. We've seen some of the changes the government has been implementing. Some of this has been quite painful if you think about the shift from NHIF to SHA, and even within SHA, the different pillars that is there. So change in itself is neither good nor bad. Usually, it's a reaction to change that gives it value, and that can either lead to cooperation or resistance. And I may be a bit biased to talk about resistance, but I also want to highlight here that you will most likely face resistance a lot more, as I said on my second point earlier, if you don't take the time or the pain to involve, to listen to empower the people in the process. And I think we've also clarified at the beginning that you have to create a climate most likely be successful. And so we'll talk about that also in a minute. What then are some of the common errors that people make when it comes to drive change? Number one, allowing too much complacency. Again, a very classical example is usually government. As you've seen, is event shift. There's a very painful change a couple of years ago when the government shifted to the e-citizen platform, and all the payments needed to be made. And of course, if you allow complacency, we usually say like you have certain sacred cows where they can sort of get away. It really dilutes the essence, or in fact, I would say the purpose of that change. But also the other common error that people do is that they fail to create a sufficiently powerful, we say sufficiently powerful, it's not just a guide, sufficiently powerful. We'll see in the slides ahead, change initiative as the head of the institution, as the head of the unit. You cannot, as an individual, successfully be able to, institute guiding coalition, guiding, but people whose power status allows you to have much more success. The other common error that we tend to make in change is communicating the vision. It is being not explain it in a very simple way. If you ask to show you exactly what that change is going to lead to, they cannot be able to explain it. Usually we point to the fact that then at the leadership level, we have failed to make sure that we have really communicated the vision and the strategy for that particular change. They can explain it in their own way, but it aligns. It also makes it much more easier. Another common error that people make when it comes to change is failing to create short-term wins. As I said, naturally human beings resist change. And so if you really want to successfully navigate every single barrier that you overcome, every single milestone that you actually get to succeed in, it's important to acknowledge it. And you want to make sure that people know that, look, we are heading in the right direction. We are making small incremental wins. And of course, I think the biggest error that people make is neglecting to anchor changes firmly within the corporate culture itself. And I I take this especially, for example, when you look at the current shift that we have. Most of the institutions that are now getting more digital, they are adopting AI, for example, within their practice. And so you find that if, as an organization, that also doesn't get anchored within the organization, you lose opportunity to really successfully drive that change. But there's something I want to highlight as a takeaway for me from this slide. It's not enough to have a change that has failed. Change that failed tends to also create cynicism. And when you have cynicism in an organization, in a department, in a team, it becomes like a virus and it spreads rapidly, which then also makes or means that future change initiatives are much more or less in a time warp, as we like to say it. And of course, you miss opportunity to be able to grow. And I think I've highlighted this, so I won't too much about it. Change will impact them. For some, it's they feel that they might lose their job, their security is going to be gone, or they're introducing now AI. What does that mean for my job? Or you're going to be introducing a new different technology, you're going to be introducing a new different procedure. What does that mean for what I know? So sometimes you have to keep in mind, as a person who's trying to drive change, you're also asking, what do the people think? And I also want to really highlight that. And even earlier on, when I was myself teaching on change, I never appreciated the value that you cannot ignore the individual perception. Remember, you're driving change, but through people. And it's not just people as a group, but it also boils down to the individual. So, as a person who is driving change, take time to understand what are the fears that the individual has and then the team has. Often we tend to work from a team perspective, forgetting that also the individual does matter, even in that change. And in some cases, in fact, we've seen the changes end up either disrupting their cultural traditions, might have personality conflicts, might impact on the leadership style. All those are things that could easily contribute to that resistance to change. Now, uh, because of time, I won't dwell too much on the case study. Allow me just to give you a very small brief. And most of those who are slightly older would remember the case of Nakumatt. It was one of the biggest hypermarkets, actually, not just supermarkets in Kenya. And it started in the early 90s. And by 2016, in fact, they had roughly about 60 branches. Their turnover was about 60 billion Kenya shillings by 2016. One of the things that Nakumatt wanted to do was to introduce a white label within their supermarket that was known as Nakumatt Blue Label. And It did look nice. It's actually photos I took from newspapers, just articles around that particular time. And so the intention for Nakumat was to make sure that they could actually sort of, their argument, let me put it that way, was that they were not only diversifying, but increasing an opportunity for local suppliers to be able to supply Nakumat through the white label. Now, the interesting thing, of course, is that at the same time that they were introducing the blue label or the Nakumat blue label at that particular time, it also began a process because some studies have associated the initiation of the decline of Nakumat around the same time. And everything that they had said, because as I said, they thought that by introducing the Nakumat blue label, they were going to actually increase their market share. They were going to give more business to local suppliers, but that was not the case. And when you look at the articles, you can see actually this quote here from at that time the chief marketing officer, the CMO. He said that Nakumat blue label would directly support industrialization efforts while providing a lifeline for local manufacturers. Remember, I told you in 2016, Nakumat was doing 60 billion Kenya shillings. Literally, they were, having a pulse impact on Kenya's economy. Unfortunately, things began to go down south, and in fact, by 2017, the first red flag at that particular time, or the ranged parameters, was when, of course, they were not able to pay a debt of about 60 million owed to African cotton industries. Most of you know this because it's one of the biggest manufacturers of cotton-related products, including tissues. Now, 60 million, considering as a check, is a very small amount if you're making 60 billion. Yeah, but that in itself set in motion a process that eventually led to a number of suppliers then coming out, a lot of debts that the Nakumat was owing to various suppliers. Remember, as I said, you can trace this to almost 4 or 5 years earlier on. Now, what I'm trying to link this is that despite an attempt by the founder to try and salvage Nakumat, it was by that time, as I said again, by 2017, already a sinking ship. Any efforts that were done, including trying to pitch the government to put in resources, government declined because they said that this is not a public-owned asset for that matter. And so they went back to court. They lost the case, and eventually they were put on an administrator. And by I guess around mid of 2017, already the decision had been made to pull the plug. And as I said, switch off the life machine on Nakumat. And at the end of that 3 years, Nakumat completely went. Now, what I want you to think about, and as I said, I'm going to link it to what we'll be discussing as we finish about changes. If really there had been a thought process that had been put in place to try and introduce this Nakumat blue label, and if then the initiators of this change had really taken time, and I've only picked on one thing that, as I said, most of the studies have attributed to part of the contributing factors of the collapse of Nakumat. There are about 16 things, by the way, but this is one of the ones that was also highlighted. If that was the case, and a team had really been put in place to do a background check, work with the suppliers, have a more effective way of launching it into the organization, and Nakumat had then taken time to remove the barrier so that the Nakumat blue label would have been accepted even much more easily, the suppliers, would they have failed? That's a rhetoric question I'm asking you. But of course, I think through the association, you'll get the slides and you can be able to take time yourself. And you can also research a lot more. The point I want to put across, or rather my argument here, is that if the change had really been thought of, if it had been executed successfully, and amongst many other things, there might have been hope to actually turn around the institution. I did mention about the 8 stages of change, so allow me not to dwell on this. I want to go into these steps individually. Now, we said the first step, as I said, is establishing a sense of urgency. Please remember that, and then having a powerful guiding coalition, and then having the vision. But where do we fail when it comes to creating that sense of urgency? Some of the behaviors that sometimes have been attributed to making that change less likely to take off is complacency. Sometimes it's arrogance or false pride or immobilization, where people feel like, if it's not really that broken, why should we fix it? In some cases, we've seen rebellious or defiant behavior to change, by the way. and pessimism, of course. Remember, this is just the first stage where you're saying, why do we need to change? Why do we need to change? And is it possible that sometimes if you don't change, you get overtaken by events? I know most of you are familiar with a lot of the business case studies that are out there from Kodak, from Nokia, from now Nakumat, and even in some cases, I guess also Taskis. When people have that pessimism to change, there's a risk, and as I said, you will not be able to move. What are some of the things that you can do to be able to drive that quick sense of urgency? It's showing others the need for the change. And sometimes you might actually need to use a compelling object that they can see, they can touch, and they can feel. So if you want to introduce, for example, a different process or a different procedure, people can actually get to see an example, that this is what would happen if we actually get to change. And all I'm trying to argue is that that might be much more effective than just giving people Excel sheets and PowerPoint presentations. Number two is also showing people valid and dramatic evidence from outside the organization that demonstrates that change is required. And this, by the way, has been successfully used, especially again within our field. If you think what we tend to call highly reliable organizations, they've benchmarked and said, look, this is what the world class standard is looking like. This is where we can be able to get to. And people are able to see that. And of course, if you're the person who's also driving the change, you need to be able to reduce the complacency, and you don't underestimate how much complacency or fear or anger exists. And again, I'm just emphasizing, remember to address the individual, because that's where your biggest problem is going to be. So if we are saying as a first one that we need to have a high sense of urgency, the second thing, therefore, is having a powerful coalition. It's not just a guiding coalition, but a powerful coalition. Why do we insist about power? Because when you have people that are also perceived as being respected, their key opinion leaders, they are well-respected peers within that particular department, the organization, for example, this kind of a team is likely to have a much more positive impact on the change. Why? Because that position of power is going to help you. Their expertise will also come in handy. Their credibility helps you, so that when people see that that team is the one that we aspire to be, they get that credibility that might allow them to be able to change. And of course, they would be respected leaders. In this one, I want to say what does not work. When it comes to getting a guiding coalition, the biggest mistake sometimes we do is to get a weak task force, single individuals or governance structures that are not really, I would say, have the buy-in of the people. That doesn't work. Or confronting the situation when a momentum and an entrenched power centers undermine. So trying to ignore when you know that I have this team that is meant to be driving change, but there's a power struggle within the team, that change will not see the light of day. And so when sometimes we make the mistake to assume that people will not see it, they will see it. And remember, the guiding coalition is the second step that helps you to drive successfully the change. Or in some cases, as we have seen, places where people decide that because the head of department or the chair or the team lead is get everybody else on board, and then wait, the the team lead or the chair will catch up. You need to have, especially the person who is leading that particular team, to be on board. And when you don't do it, it's less likely that you're going to be successful. Which brings me to the third part. Remember, you have created a sense of urgency, powerful guiding coalition, and therefore you now need a very clear vision. Where do you be in? That's extremely important. And what works here is trying to be as literally descriptive as possible. People want to feel that future, visions that are so clear that they can be articulated in 1 minute by anybody within the team. It's not just going to be, for example, the head of department, all the way down to the person that actually cleans the theater. They are able to say, this is moving in this direction. Visions that are moving and that people can commit to and relate to are bold. Would you like to talk that is called, the strategic question is able to be people in a very simple manner. It's extremely important. And I want to emphasize that again, it's not PowerPoint slides, Excel sheets, it's a 8-page document, articulating why the change needs to happen. You need to make it as simple but as believable as possible. That's very important. Which brings me to the second 3 stages. And the fourth, of course, now that you have clearly articulated the vision, is then communicating it. And then making sure that you have a broad-based action. How that sounds with the political intonation, but it's not what you're thinking. And then making sure that you're able to snowball. I want to focus here on what does not work. They're communicating. If you have decided that there's going to be significant within the department, there's going to be procedure, there's going to be a new approach, maybe a new SOP, a new practice, whatever it is that you are introducing, you have to make sure that you do not under communicate it. Ask as many questions, have as many roundtables, have as many town halls, take people through the process again, ask somebody to explain it. That will help. Another thing that does not work is speaking as though you're transferring information. And so some of the mistake that people do is they come and say, look, as your head of department, in the last management meeting, I have been asked by the hospital management that we have that you're actually buying in yourself into the change. How then will the team buy in? And of course, as the change champion or the leader, yourself can also be a risk, because people will see that you're not really walking the talk. Oh yeah, we have to do this. If we don't, we're going to have problems with management. I'm not sure it'll work, but let's do it. That creates doubt. That calculate. And remember, as I said, people already resist change anyway. So you're only giving them more reason. And we did say that a change that is failed creates cynicism, which becomes like a virus. It becomes very difficult to change thereafter. And I'm sure if I ask this rhetoric question, do you know organizations, hospitals, clinics, practices that are still behaving like they're in the 1980s? I'm sure most of you still do. Okay. The reason why they are stuck is most likely because, as I said, at some point they lost an opportunity to be able to change. The world is changing. I believe also so are the patients. Now, of course, we've, as I said, made sure here that we are really communicating that particular change. Now, what are some of the things, again, that can help you in terms of getting that momentum with the people? Number one is finding individuals with change experience who can sort of give you a boost. They're like a turbocharge. Having a recognition and reward system so that the people who are actually onboarding much more faster are recognized. They are also acknowledged. They get a certificate, they get trophy, they get acknowledged, they get a note, a mention. They are also recognized by the management. They get to go to that corner for the employee with a significant impact. Whatever it is, that helps. And to see that we actually making headway, they're being recognized. As I said, it becomes like a turbo charge. And so the best way also in driving this is making sure that you're using those small wins to have it to snowball. And snowball means that you will not just get success. You use it to be able to actually move on much more faster. And so focus on what works. You make sure that, of course, you have early wins that come fast in terms of time. You make sure wins that are visible as possible to as many people, because that will also galvanize a lot more within your team, your department, your organization. Wins that also penetrate emotional defenses. Remember, as I said, people who are resisting earlier because they don't know what it means for some of them, and making sure that those wins are meaningful to others. That becomes important in using those small wins to generate the momentum, which takes me to the and the present bottom very nice looking graphs. But as I said, sometimes that is not exactly what is being implemented. Another thing that doesn't work is convincing yourself that you are done when you aren't, simply because of the small wins. So you've not yet achieved the milestones that you had set, or convincing yourself that you can get the job done without confronting some of the embedded bureaucratic and political behaviors. And by the way, maybe in another forum, we'll talk about organizations as political arenas. And so, whenever it is that you're working, you have to remember that as long as it's an organization, as long as it is, a department, it also behaves like a political arena. So you cannot ignore or bury your head in the sand when you know that there are also political machinations that do play a role in terms of some of the investments, some of the support, whatever it is that you can look at it from an organization. Ignoring it only makes it more difficult. And of course, you don't want to push yourself too much. The last and very important stage in change management is in anchoring those new approaches within the culture. For the process that you have now decided that you want to introduce, I remember discussing with one of my good friends who was an ENT, and they were telling me how they wanted to sort of begin changing the specialists that they were hiring, because they were looking for a particular, I would say, culture they wanted to inculcate. And I was saying, one of the things that you need to actually put in is a description itself of the people that you want. If you want people that also embrace maybe this flexibility or this change or a certain approach, in order for you to successfully begin to shift the organization, it also has to be anchored within the culture. And what works here is you don't stop until the change has roots. You use, for example, new employee retention to compellingly show the recruits what the department or what the hospital, what the organization, what the business really cares about. You use promotional processes to place people who act according to the norms into influential and visible positions. So, because the last thing you want is to promote somebody who is against the change to lead a team that was probably embracing the change. As I said, it's almost akin to shooting yourself on the foot. And the other thing that works is making absolutely sure that you have the continuity of behavior and results that help a new culture grow. That help a new culture grow. I want to remind you that human beings by nature resist change. That's how we are. That's how we have been. Okay. And so it sort of really then, gives me a pleasure to sort of contextualize this by saying that in the end, as I said, we've also moved to this perspective that people need to be able to see, help people see with compelling, eye catching, and dramatic situations that this is the change, ladies and gentlemen, that we need. Let them be able to feel, because emotions drive change. Emotionally encouraged ideas most effectively change behavior. And when they do that, you will then begin to see the change. And it will allow you to have, use those compelling visualizations that provide useful ideas. I want to take you back as I finish to the case study that we had said. Assume that the entire organization is galvanized, if it was Nakumat, and people really saw why they needed to put their heart, their soul into making sure that they take care of their suppliers, that the project itself is successful. At the very least, one thing that they would not have bled is losing revenue. Forget about the other, they had other issues that, of course, contributed to the collapse, but they would have maintained their suppliers. They would most likely have had at least an ongoing business that was having some form of cash flow. Why? Because people begin to see that this is exactly, and they can feel the impact of that particular change. I'm just giving a hypothesis. But in conclusion, I want to say that turbulence, or for that matter, change, never ceases. In fact, there's something that we have learned. If we look at the current happenings, especially in the Middle East, change will always be the one constant thing. But the single biggest challenge in change process is changing people's behavior. And don't forget that the only way you can succeed is by focusing on also the individual, not just the team. And the key to this behavior shift is less about analysis and thinking and more about seeing and feeling. When people begin, and my quote, Tangatia is, as I live today, is that example is not the main thing influencing others. It is the only thing in change. That way, people will see, they'll feel, they too will want to change. Thank you so much. And back to you, Dr. Ngatia.
Thank you so much, Mr. Newton. That was a very nice and impactful topic. I feel like it will change so many of our lives in terms of even our management and even bringing new ideas. And clearly, many of us should not be resistant to change. We should be willing to change with the times. Kindly, I'm checking the chat box. Could we kindly get this recording? Yeah, I think that can be organized. Don't don't know if there are any other questions, but thank you so much, Mr. Newton. At this particular point, maybe allow me to invite Cynthia, who are part of our sponsors for this CME, to give us a small, maybe 5 to 10 minutes talk on a product as they're sponsoring since they're sponsoring the CME. Welcome, Cynthia.
Thank you, Dr. Ngatia. Allow me to share my screen. So good evening, everybody. My name is Cynthia Aloch. I work with Phillips Therapeutics. I am in the critical care unit, and today I will be sharing with you about one of our products, which is Themiset. Themiset is available as palonosetron. We have two strengths, 75 micrograms and 250 micrograms, but today we will be focusing on the 75 micrograms IV injection. So this product is targeted for anesthesiologists and intensivists for management of postoperative nausea and vomiting. So PONV is 20 to 80% an incidence in post-surgery, and it is the second most feared surgical complication. And postoperative nausea and vomiting can be managed by giving this IV dose just before induction, and it has got a sustained half-life of 40 hours. So the consequences of uncontrolled nausea and vomiting postoperative, as indicated here, we have delayed discharge and PACU stay, that is prolonged PACU stay, unexpected hospital admissions for daycare cases, wound dehiscence risk, dehydration and electrolyte imbalance. We can also get patient dissatisfaction and increased healthcare cost. So there are many factors, risk factors, that are associated with postoperative nausea and vomiting. First, we have the patient factors, which are the female sex, a non-smoker, motion sickness, or history of postoperative nausea and vomiting, and post-op opioid use that is anticipated. Also, we have the surgical factors that, for example, for cases of laparoscopic surgery, gynecological procedures, ENT and ophthalmologic surgeries, and also surgeries that go beyond 1 hour. And also we have anesthetic factors. For example, if you are going to be using the volatile anesthetics, high dose of neostigmine can also be a risk factor. Use of nitrogen oxide, and also inadequate analgesia. So the APFEL score is the most simplified risk score for postoperative, and it helps in stratifying PONV risk. Post-operation. One point, a score of 1. If they are a non-smoker, that's another point. If there's history of PONV or motion, that's another. And postoperative or opioid use is anticipated, that is another point. So the postoperative nausea and vomiting risk by score, if your patient scores 0, that is, they are neither female or neither have history or they're non-smokers, there's no prophylaxis generally. If you're the prophylaxis, which is recommended. They score 3, then triple prophylaxis, which means you include Themiset 75 micrograms. If they score 4, then you include multimodal plus consider doing TIVA, and Themiset is essential in this score. So if your patient has an APFEL score of equal to or greater than 2, then it is recommended that you administer Themiset 75 micrograms IV before induction of anesthesia. So what is Themiset? Themiset generally is palonosetron, available as 75 micrograms in 1.5 ml vial injection. It's recommended to be given as IV bolus, and it's a second generation antiemetic. It's indicated for prevention of PONV and recommended to be given just before induction as a single IV dose. So why Themiset? We recommend that you give Themiset to your patients because one, Themiset offers the longest half-life, which is 40 hours, and this covers the entire postoperative window without the need to redose. And it has got the highest receptor affinity, that is 30 times greater 5-HT3 binding versus ondansetron or granisetron. It works through the allosteric mechanism, and therefore it has got a action, and therefore there is no need to repeat dosing in the PACU. And also it offers minimal QTC, therefore meaning it in ICU settings. It offers specific benefits, which means it has got superior delayed phase post-operative nausea and vomiting control, that is 2 to 24 hours post-op. And also it is a guideline endorsed product. So clinical indications and patient selections for Themiset, that is who needs to be given Themiset 75 programs. So those are high-risk postoperative nausea and vomiting prophylaxis cases, that is any patient that has an APFEL score of equal to or greater than 2. Also ICU or post-op nausea control for critically ill patients, especially those who are mechanically ventilated, patients who with nausea, post-cardiac surgery cases, opioid infusion-related nausea in ICU, and patients with nasogastral tubes where PONV is harmful. Another patient selection is those patients where we are going to have to rescue in special situations where the first generation agents like ondansetron fails. So for patients who are experiencing refractory PONV breakthrough post-op, patients with cardiac risk, that is QTC concerns with ondansetron, patients with PAC failure requiring stronger 5-HT3 blockade, and pediatric PONV, even is off-label. So for risk stratified prophylaxis protocol, for APFEL score of low, this is a repeat of what I had said at the beginning. There's no routine prophylaxis, rescue antiemetics available that if needed, and moderate monotherapy, that is giving Themiset 75 micrograms IV. High, which is an APFEL score of 3, then you need to do a combination of Themiset and dexamethasone. And very high, which is a score of 4, then you can go for triple or quad prophylaxis, which is Themiset, dexamethasone, droperidol, and also consider TIVA to avoid volatile agents. So this is a comparison of Themiset versus the first generation 5-HT3 antagonist. And we see that palonosetron offers better therapeutic effect with a higher half-life, better affinity, and also convenience of dosing. So benefits of Themiset 75 is that it offers superior late phase postoperative nausea and vomiting coverage. That means it is active through 24 to 48 hours post-op, exactly when delayed postoperative nausea and vomiting peaks. Also, Themiset is a single pre-induction dose, so there is no operating room interactions, there's no PACU redosing, and also it reduces nursing burden significantly. Number 3 is that Themiset has got minimal QTC prolongation, and this is a critical advantage in cardiac patients and those on QT prolonging anesthetic drugs. Also, there's enhanced patient satisfaction when there is better PONV control. Themiset also offers multimodal protocol compatibility because it is safe to combine with dexamethasone. And also Themiset can be used in the ICU. It is effective for opioid-induced nausea in mechanically ventilated and post-op ICU patients. Themiset is guideline endorsed, and there are studies that can be accessed online, and we are also ready to share for anybody who needs these studies. There is also Themiset offers reduced healthcare costs because of fewer PACU complications, meaning this leads to shorter stays and there's lower rescue medication use. So the key conclusion and key takeaways for Themiset. Themiset 75 micrograms offers precision anti-emesis for every perioperative setting. And we all agree that postoperative nausea and vomiting is a major clinical burden. And therefore, it is good when we have a product that is able to assure us of this management and also give us that prolonged cover throughout the postoperative nausea and vomiting window, which is up to 24 hours. So a single dose, complete perioperative cover with no need to redose. So we kindly recommend that you use Themiset 75 micrograms to protect your patient through every hour of recovery post-op. Thank you. In case of any queries, I hand it back to Dr.
Thank you so much, Cynthia, for that presentation, for reminding us about even the triggers for post-op nausea and vomiting and how we can combat them. Just a quick one, is there availability of Themiset in public hospitals or maybe in KEMSA?
At the moment, yes, we have Themiset available, but not at KEMSA. It is available at MEDS.
Oh.
So the public hospitals get it through MEDS. Yes.
Okay. Thank you very much. We have a few questions. Maybe Mr. Newton, in our chat box, I will be reading the questions. You can give us some insight on the questions. So someone is asking, what will you do about a boss who is resistant to change initiatives, assuming you are the boss of that boss? And another question. Yeah, oh, sorry. Do you want to? Okay. Maybe
yes. No, I was going to say, Dr. Ngati, I can say what you cannot do, and I know it doesn't have. What experts say is you cannot ignore that boss who is resistant. So I just want to clarify. The biggest mistake we tend to do is to assume that because I am the boss of that boss, I can go ahead and drive the change without requiring that boss, but it often backfires. So it means you might need a bit more time, but you need them to really be on board. So the suggestion is to sit down, often find out what are some of the fears that they might be having, what are the issues they have with the change. So that conversation might not happen overnight, but hopefully because it's somebody that you've also hired and there must be something that they're good at, you can be able to strike a balance so that they also begin to thaw and buy in, but you need them on board. That's what I would emphasize. You cannot ignore them just because they seem to be resistant and yet they're the team leader. Thanks.
Okay, thank you so much. That was Dr. Okia. Dr. Nabulindo is asking, when implementing a change idea, what are some signs you are failing and you should stop?
That's an interesting question. Usually, we say that the first thing is having that that sense of urgency, and then having a guiding coalition. Then we said you need to have the vision and strategy being clear. So at the place where you've sort of set that this is a vision for the change and this is a strategy, you would obviously maybe also have certain milestones that you'll also be linking it to show that yes, you're heading in the right direction. So I think you can sort of put in place a feedback mechanism that tells you if we are not getting this milestone, then it's likely that this change is not helping. So it could be, for example, let's say optimizing medication. Maybe you want to introduce an infusion pump and see, does it help us, for example, in terms of reducing any wastage that we have. So one of the parameters that you'll actually be putting in place is to see whether there is reduction in terms of wastage. And so there are many things that you can be able to put in. You use those KPIs to make sure that at every step you're measuring whether you're getting those outcomes or the outputs that you had anticipated with the change.
Okay. Maybe just to add on that, would I ask if setting like maybe time frames within which you may want to achieve a certain goal and maybe evaluating it, will that help you also?
It does, Doc. But keeping in mind that you sort of address, as I said, some of those inherent fears that your team or the organization might be having. Remember, as I said, it boils down to the individual. Usually, the change will, for it to be successful, the people have to fully be on board. So if you know that, for example, now people have embraced the move from the stage where we had said of denial to exploration, then you know that actually they've thought and now they're accepting the change. You can begin to put concrete sort of timelines that this is by this is when we need to have. So that's just an important factor to consider.
Okay, thank you very much. Dr. Susan Jeroge is saying these are great insights. Thank you. So what practical strategies have you found most effective in engaging people who are skeptical about change?
I think for me, from where I sit, and it's one of the slides I did share, is to find out what is their biggest concern. Usually, I tend to relate the fact that the higher the skepticism I have to the change initiative I'm talking about, it most likely means that I wasn't probably as visible, as demonstrative, or I didn't really create a sense of urgency. Because when you do that effectively well, people are jolted that if we don't change, then we will not actually be able to move. So it means you might need to take a step back and ask yourself, by the way, have I really created a sense of urgency? Because it's not going to really make an impact or move the needle. They'll most likely remain skeptical. Think of it, I would say, maybe in terms of, say, it's like we are a patient. If this patient's parameters are so deranged and we know that there's a high risk, for example, of getting a very severe complication if we don't, or even losing the patient, then people will work round the clock to really try and make sure that that doesn't happen. So when you don't see them, that we
Oh, that is very nice. Thank you so much. I feel like you have enlightened us in a very different perspective from our usual medical series. So thank you so much, Mr. Newton. I think there is no other question. So thank you very much, everyone. I don't know if there is any announcement from KSA side.
There is one more question, Dr. Eunice.
Okay. There being no other issues being raised, thank you everyone for attending the
I see there's a
CME.
question. Sorry, Dr. Eunice, I see there's one question. Maybe we can take from Dr.
Oh,
Kevin.
sorry, I hadn't seen it.
Yeah.
Okay. Dr. Kevin Omani, supposing you feel a certain change is going to affect negatively in a department, is it okay to quit?
So if you're if, for example, you're part of that department and you feel like this change is going to have a negative impact, I think I'm hoping that the people who are initiating the change, as we said earlier, are taking time to be able to discuss, create the climate, because you have an opportunity to be able to push back. Usually, our assumption is that a highly functional team is one where there's also trust, or at least there's an element of trust within the team. So your input might actually help, and maybe giving your perspective as to why that change will not result. And of course, at the same time, making sure you also listen on their side of the argument. So I would prefer that way than quitting. But I also understand that some people usually find it difficult if they find themselves in a very toxic environment and they feel like their opinion, for example, is not really considered, is not even solicited, is not even picked when they say. So in that case, sometimes you have, of course, to keep that with maybe historical evidence, and you make that choice. So I would presume, Dr. Omami, that at that point maybe you're much more keen on your personal wellness, and you feel like stepping out might actually be much more good for your own health. But as I said, in an ideal situation, it might be important for you to give your opinion and your thoughts as to why you feel that change might not have the best outcome for the team or for the organization.
Okay. So once again, thank you so much, Mr. Newton Siele. Also want to thank everyone for the engagement in the chat box and even participating and even coming for the CME. Without any other announcements, I wish everyone a blessed evening until we meet in another CME series. Thank you.
Thank you so much.
Thank you, Dr. Eunice.
You're welcome.